All right, this is chapter 21. It begins on page 537 in your textbook, and this chapter is focusing on the abdomen of a patient. So first off, just kind of remember the anatomy of our patients here. This is the internal anatomy, some of the things that we're listening to and palpating and inspecting. And then we can do some deeper palpation and then also some auscultation of these other structures underneath those superficial organs. These are the deep internal organs. So remember that we are splitting our abdomen into 4 different quadrants when we are documenting anything abnormal or even normal. RUQ stands for right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. There's also another type of documentation that we do. If it's right in the middle at the top, we call that the epigastric region. If it's around the belly button, that's the umbilical area. And then down below the umbilical area, above the pubic bone, that's going to be the suprapubic or hypogastric. So these are mainly just for documentation purposes. But you can see there's several things located in each quadrant. The right upper quadrant houses the liver and the gallbladder, also different portions of the intestines there as well. The left upper quadrant, the things that we look most for there would be the stomach and the spleen, and then also kidney is in that as well. The right lower quadrant is cecum. For female patients, we're looking at ovaries, and also for all patients, ureters, and also McBurney's point is located in the right lower quadrant. This is going to be helpful maybe later on when we're looking at diagnosing appendicitis. The left lower quadrant is going to be that descending colon, the sigmoid colon, and then also on the left side of our patient's ovary, ureter, and spermatic cords. And then that midline that we looked at that contain that epigastric, umbilical, and suprapubic is the aorta. Also in a female patient, we may be able to palpate the uterus if they are, if the patient is pregnant or if they have some other cyst of some type, and then also the bladder could be palpated, but typically only if it's distended. The aging adult, looking at the elderly patient, of course, we do see the abdominal wall change slightly, not as much muscle, and also not as much subcutaneous tissue sometimes in that area, sometimes more. Other things that happen with the GI system typically have less salivation, so they don't usually have that need like younger individuals do for thirst. We also see the peristalsis tends to slow down. The gallbladder tends to create more gallstones. The liver size typically decreases, but the function usually stays pretty normal. But we do know after pharmacology that our drug metabolism does seem to be impaired or slowed. And they have lots of problems with reports of constipation. So let's talk a little bit about that constipation. Some of the common signs or causes of the constipation with an elderly patient is because of being too still, no physical activity, not drinking enough fluids because their body doesn't demand that like a younger patient's. Also just not eating the correct foods that have fiber in them, being on more medications. You guys can read this. Hypothyroidism is more likely in elderly patients. And then also, we do have to remember that if we have a patient that does have a tendency to be incontinent, they may try to hold that stool in more, so then it does become more difficult for them to use the restroom later on. So some of the things that we look at with culture and genetics with our abdominal area is obesity. It does play a big role in genetics, and they're finding more ties to that now. This has been happening, globally, and we can see differences in obesity among racial groups, which show that it does have a pretty strong genetic tie. Of course, the other things that we do look at is that kind of nature versus nurture, where you raised with a bad diet and therefore you still don't eat well as an adult, those types of things. Okay, so now we're getting to some of our questioning of our patient. And so the first things that we're going to get to here is appetite, dysphagia, and food intolerance. So with appetite, we need to know, has there been a change, a gain or a loss of appetite, and also any change in weight. And if they do have a change in weight, we do have a few more questions that we need to ask here. Was this intended loss or not? The other thing that we do have to kind of make a mental note of is that anorexia, although this is a term that's been kind of coined really bad in media, sometimes people can just have anorexia from medications or even mental health disorders, but we do have to keep in mind that it's not always a choice that they're making to not eat. Dysphagia is difficulty swallowing. If they do have that, we need to note when they first notice that. If they have dysphagia, usually they've got something going on with their throat or esophagus. Food intolerance, anything that they can't eat, what happens if they do eat them, and then antacid use belongs here as well. So abdominal pain, once again, if they say yes to any type of pain, we have a lot of questions to ask about that. If it's moving or not, we need to know that. Because if it moves around, this could be something that is going into maybe the bowels. How did it start? How long have you had it? Does it come and go? Does it occur before or after meals? Because sometimes we have some ulcers that tend to be linked to when we eat food. Have them describe the pain. Try not to put any ideas into their head. And then, is the pain relieved by food or worse after eating? So we do have some more questions here while investigating into their abdominal pain. We do want to know if it's associated with anything, their menstrual period, stress, do they have any nausea and vomiting, gas, fever, rectal bleeding? Lots of questions to ask if they say yes that they do have pain. Also, we need to, once again, look at what makes the pain worse. Food, position, stress, medication, or just getting up and moving around. We do need to look at the difference between, is this acute pain, something that could be like appendicitis or a gallbladder attack, maybe even a bowel obstruction, or is this something that's chronic, something that's been lasting for quite a while? That's going to be more of like our gastric ulcers, duodenal ulcers, anything like that. And then what have they tried to help relieve that pain? Medications, heating pad, just moving into a different position. Lots of questions to ask when they have pain. We need to ask them if they've had any nausea and vomiting, and if they have, we have tons of questions that we have to ask to follow that up. How often? What does it look like? What does it smell like? Are we also having diarrhea, fever, and chills along with this nausea and vomiting? And then also kind of get a little history of what they ate in the last 24 hours as well, because this could be something related to food poisoning. Now remember, if there's blood in their vomit, that's called hematemesis. So if we're charting something like that. We're also probably going to ask them if they've had any recent travel anywhere. Where to, anything about like the water that they may have drank while they were abroad, or certain foods. those types of things. We're also going to ask them about their bowel habits. We ask them when was their last bowel movement, do they have any issues with diarrhea or constipation, any changes in bowel habits, if they use laxatives. Then we're going to ask them about their abdominal history, asking about any GI problems, ulcers, gallbladder issues, liver issues, appendectomy, anything at all. Hernias, we need to know about all of those. But remember, once we do get a history that they have something going on there, we need to know the dates that anything happened, the surgeries that may have resulted from that, and then any other x-rays or radiological studies that were done. And of course, medications belong in this subjective data questioning. What are they taking? How much alcohol do you drink each day, each week? When was the last time? And also smoking. And then we need to do that nutritional assessment. And usually that's a 24-hour recall, having them tell us everything that they ate yesterday, starting with breakfast, and then seeing what types of foods that they actually have access to. Some other questions that we do need to think about for the aging adult is how do they get their food? How do they prep their meals? There's just a lot of questions that we ask them because they might have limited access to the grocery store. They might be on a fixed income, so they can't really afford much. Also, we get that 24-hour food diary. Also, looking at any issues with dysphagia, so swallowing issues. And then asking them more specific questions about bowel movements because of the constant reports of constipation. Okay, so if we're preparing now to do that examination, get that objective data, the lighting should be a nice strong overhead light, preferred secondary stand light so we can kind of shine the light across the abdomen. We need to expose the abdomen so it's fully visible. Make sure that their genital area and also any females have their breasts covered so that they're in a comfortable position. Anything that's going to help that abdominal wall relax so we can actually assess what's underneath that even better. We do want them to empty their bladder prior to any abdominal examination, but make sure we get a specimen if we need that. Warm the stethoscope so they don't pull away from that and have some guarding there. And we're going to auscultate or listen before we palpate and percuss. And this is because when we palpate and percuss, we are going to trigger their intestines to have more peristalsis. So we want to auscultate first to hear what their normal peristalsis is before we palpate and increase those noises. So when we inspect the abdomen, we're looking at the contour. We usually stand on the patient's right side and look down that abdomen. That second light becomes a little helpful here. Our head does need to be slightly higher than the abdomen so we can see how the contour is. And you'll see on the next slide kind of a description of each type of contour that we may see. Symmetry. So once again, shining that light across the abdomen towards yourself. Should be symmetrical bilaterally, but if there are any bulges or masses or asymmetrical shape, this is the time that we note them. Even a small bulge is going to be highlighted because of the shadow that's being cast across by that light. So some of the bulges that we may see are hernias. We could also see some different nodules around the umbilicus if there is a cancer issue going on as well. We also, just from this symmetry, Could also see bulging of the liver, an enlarged liver or spleen at this time too. So this is the contour of which I was talking about, and it's basically how does the abdomen look between the pubis and the bottom of the ribs. So is it flat? Is it scaphoid where it drops down? Is it rounded? Or is it protuberant where it really pooches out or flows out much further? So the next thing that we're going to look at when we're inspecting the abdomen, so we haven't touched them yet, we're just still looking from afar, is the skin. What we may see are striae, which are stretch marks, because they don't have that elastin in their skin. We also want to be looking for any type of moles, any papular areas that's very common on the abdomen. We do also want to make sure that there aren't any lesions, because if there are, we need to document those well. And then also if there are any surgical scars that may be healed at that time. So some of the surgical scars we could see are for you on page 547. If they've had an appendectomy, they may have that one in the right lower quadrant, that 6 centimeter scar. Anything within the bladder or maybe even a C-section, you're going to see that vertical scar between the umbilicus and the pubic bone up to maybe 11 centimeters there. And this is just some more information on scars. It does let us know, though, that if we see those scars, there could be some underlying adhesions and fibrous tissues that could cause some issues with the bowels. And that may be attributing to some of their pain if they are having pain. Also, when we're inspecting the abdomen, we need to look for any type of pulsations. Normally, we may see some pulsations from the aorta, but it shouldn't be extensive. If our patient is thin and their muscles are nice and relaxed, that's when we might see that. We also want to look at hair distribution in the males and females, and then demeanor. Are they relaxed? Are they comfortable? Or are we seeing some signs of pain? Okay, so now that we are done with inspection at the abdomen, we move on to auscultation. And we don't want to move on to percussion or palpation because that can increase peristalsis, so we want to listen first before we move on. We're going to use the diaphragm in peace because they're usually high-pitched sounds. We are going to hold it just lightly against their skin. We're not going to push too hard because this could be considered palpation and increased peristalsis. And we usually start in the right lower quadrant and kind of work ourselves around clockwise, kind of following the route of the large intestine. So when we're listening to bowel sounds, we need to note the character and the frequency. Bowel sounds are movement of air and fluid through the small intestine. Depending on the time since last eating, we do have a wide range of normal sounds. Typically right after eating, we hear a lot of gurgling and movement of fluid. Bowel sounds themselves are pretty high-pitched, gurgling, 50 to 30 times per minute, but don't bother to count them because we don't actually document how many times we're hearing in that minute. We do need to judge, though, whether if it's normal bowel sounds, hypoactive, or hyperactive. So hypoactive sounds are loud and high-pitched. Hyperactive sounds are, it sounds like rushing, and you can kind of hear a tinkling sound as you hear that. Hypoactive or even absent bowel sounds, even though it's really unusual to chart absent bowel sounds, usually are after a surgery of some type. And so we kind of expect them at that time just because of the maybe inflammation from the surgical procedure or from the anesthetics. The bowels just have to wake up a little bit. In order for us to chart that they have no bowel sounds, we have to listen for a full 5 minutes to the abdomen by our watch before deciding that they're completely absent. So just keep that in mind. We can't just listen quickly and chart absent vowel sounds. So as we're listening to the abdomen, we're going to note the presence of any vascular sounds such as a bruit. Bruits are unusual. We should not be hearing them. But there are some certain points in the abdomen, and if you turn to page 549, you'll see the image there of where we may be hearing bruits. Like I said, it's not likely, but typically if you hear a bruit, that means we have some sort of aneurysm or some could just be hypertension also that we hear. And that, once again, is unusual. The other thing that I also want to mention is when we auscultate the abdomen, there is a procedure when we put down an NG tube. And you'll see nurses do this, that they'll listen, they'll auscultate to hear that air being pushed through the NG tube to document that the NG tube is in the correct place. Now, that is not the best way to document that NG tubes are in the correct place. Evidence-based says we need to confirm by an x-ray. We can also get a pH strip from the fluids that we pull out from the stomach. That's also going to tell us that we're in the stomach instead of the lungs. But we can actually mishear things. It could actually be vowel sounds that we're hearing instead of the air being pushed through the NG tube. And I tell you this, but you are still going to see nurses do this. You'll probably even hear some of us say, after you drop an NG tube down, just listen for that air, and that's just not the best way to do it. And it's really proven through research that X-ray is the best. All right, so I've taken out many of the slides on percussion and tympany because we don't generally do percussion. If we do, we usually have a reason why. We may be expecting an enlarged liver or the spleen. Generally, though, we're going to inspect first, then we're going to auscultate, and if we do percussion, it will be next. So what percussion is going to tell us is the location of organs. We can also screen with percussion for abnormal fluid or masses. And when we use percussion and or tympany, we're going to move clockwise around the abdomen. That's pretty much all I want you to know about percussion. We can practice doing this in the lab, but it's not something that we use on a daily basis. What you will see surgeons and also nurse practitioners using this technique, but not typically nurses. But we do palpate. We usually palpate surface, and a lot of times this is going to tell us what's eliciting pain. But there are some other things that we can use palpation for. We can look at the size, location, consistency of organs, really looking for abnormal masses, but typically the pain and the tenderness is what we're looking for. And if they have pain, they're going to be guarding or flexing those abdominal muscles, and so we're not really going to be able to feel those underlying structures unless we get them to relax. And so they may need some pain medication before we palpate too much. But we also don't want to mask that sensation of pain if we're suspecting something like appendicitis. So we do start with light palpation with our 4 fingers close together. So we press in the skin just about a centimeter, moving around the abdomen kind of in that clockwise manner. We do lift the fingers each time, moving around the abdomen. We're not searching for organs at this time, but more of looking at the surface and superficial muscle issues, and if any pain is elicited with light palpation. So we do the tender areas last because we're going to ask them first, remember, if they have any pain where they are. So if we avoid those tender areas, hopefully that their muscles hopefully their muscles will be as relaxed as possible during our palpation at the beginning. We can discriminate a little bit as we go clockwise around between that voluntary muscle guarding and involuntary rigidity. If we do have a firm abdomen, we could expect that a patient would have a perforation of the bowel somewhere where they get a board-like rigid abdomen. So we're going to be able to tell the difference between if the patient is flexing the abdomen versus it just being a hard board-like abdomen. After that light palpation, we do deep palpation. This is going to be more for identification of organs. We once again are going to move clockwise over the entire abdomen. There could be a lot of resistance with a very large or obese abdomen, so we may be using both hands at the same time for that technique. So with each technique, we're going to look at this location, size, consistency, looking for any type of abnormal enlargements, tenderness, or mass. It is difficult to get an idea of what you're feeling for, even if you have a good grasp on the anatomy. Once you palpate on someone's abdomen, it does make it seem difficult to actually note where the liver is. I mean, we know where it is, but actually feeling it, because the whole abdomen does kind of feel the same. But it does help to memorize that anatomy. Some structures are normally palpable. We do tend to have some mild tenderness even with the sigmoid colon, even if there's not anything wrong there. But if there's any other type of tenderness in the abdomen, we do need to investigate into that. And of course, if you identify a mass, we do need to verify that it's a mass versus an enlarged organ. So if we do identify a mass, we're going to look at the location. We need to do an approximate size. Is it golf ball? Is it the size of a grapefruit? Or is it even the size of a pea? The shape of it. Is it consistent? Is it a nice firm nodule, or is it kind of soft and mushy? Also, does it move easily or freely, and how does it move with respirations? We do want to make sure it doesn't have a pulse, and then we want to make sure that it's not eliciting any pain. So here are some of the normal palpable structures in the abdomen. The liver, of course, is usually palpable. With deep palpation, we can maybe get the right kidney in there a little bit. The aorta down the middle of the abdomen. The cecum and also the sigmoid colon are palpable, but those are a little bit more difficult to differentiate. And then the uterus, if maybe we have a pregnant patient, and then also if our patient has a full bladder, we may be able to palpate those. This slide is going to give you some more direction on how to palpate that liver, and this is going to be something you'll want to look over to try to do when you are in lab. This is another technique for palpating the liver. It's called the hooking technique. You're basically hooking your fingers over that costal margin from above, and when a patient takes a deep breath, you should be able to feel the edge of the liver at your fingertips. Sometimes we do need to see if a patient has an enlarged spleen. So normally we can't palpate a spleen, and it has to be pretty large to be able to palpate it. We can go ahead and look for it during lab. It's going to be, you put your hand over the abdomen and behind the left side at the 11th and 12th rib there at the base of the ribs. Lift up for support and place your right hand on that lower, or that left upper quadrant. But like I said, it's really difficult to feel that. You really should not feel the spleen. But if it is enlarged, it's going to slide out and bump into your fingertips. It really can grow so large that it is down even into the lower quadrant. So you may want to start low with this palpation just to make sure you're not going to miss it. Now we do have spleen enlargement. I want to give you some examples of why it might be enlarged. Mononucleosis is one reason, trauma, and then also with leukemias and HIV. So we are probably going to refer the person to a physician that can help them with whatever their specific issue may be, and we're not going to continue to palpate the abdomen. Another technique you may want to try in the lab is palpating the kidneys. Each of these, this slide and the next slide will kind of tell you how to do that. We're going to search for the right kidney by putting our hands together kind of in a duckbill pattern, so one on top of the other on the patient side. So one will kind of go behind the back and the other on the abdomen. You're going to have to use pretty firm pressure. It's going to be pretty deep palpation. And we're going to ask them to take a deep breath. Usually you're not going to feel anything, so you're not going to feel a kidney unless it's really enlarged. But what you could feel is maybe the really lower pole of the right kidney, but it should be round and it just should slide just between the fingers and then back out when they breathe out. Either of those are normal. If we're palpating anything else, that's going to be a referral. The palpation of the left kidney is going to be similar. But it does sit a little bit higher than the right, so it's not normally palpable. You shouldn't feel any change with inhalation. You're using the same technique, but you're not going to feel anything even when they take a deep breath, unless that kidney is fairly enlarged. Next, you'll attempt to palpate the aorta. You're going to use your thumb and your fingers on the same hand to kind of palpate that. It should be midline in the upper abdomen above the umbilicus, usually about 2.5 to 4 centimeters wide in adults, and it should pulsate. If we suspect that a patient has an aortic aneurysm, we're not going to palpate though for risk of rupturing that aneurysm. So just keep that in mind. If you have a patient that does have an aortic aneurysm, we're not going to palpate those. Now there are some different special procedures here that they list for advanced practice, but there are a couple of these that we do use. And the first one is rebound tenderness, and it's called Bloomberg sign. And we typically use that for appendicitis, and we're going to push in that right lower quadrant. You do you push down in, and then when you lift up, that's when they have pain. So that's called rebound tenderness, and we do that at what's called McBurney's point in that right lower quadrant to test for appendicitis. The other one that we do sometimes is Murphy's sign, and normally palpating the liver doesn't have any pain. But if we have someone with cholecystitis or a gallbladder issue, if we hold our fingers under that liver border and they take a deep breath, that may elicit pain if we're having gallbladder issues. The other exams on here we do not use. The ellipsoid muscle test and the obturator test. This is a patient is moving their legs, and of course that's going to elicit abdominal pain if they've got something going on there. So on the aging adult, remember we're not going to see the increased amounts of subcutaneous tissue typically on the abdomen and hips, or we may see it increase, The abdominal muscles do tend to be thinner and have less tone than a younger patient. The organs may be easier to palpate because of that. The liver is usually easier to palpate, and also it's easier because if the lungs are inflated and the diaphragm is down, we can palpate that much easier. And also the kidneys are easier to palpate. But we don't usually do a lot of palpation of organs. What I do like about each of these chapters is it has sample charting in here. What you see on this slide is a within normal limits type of a charting. Nothing's going on. But these are listed for you on page 564. And there are a couple of different case studies, 4 of them in all, that will give you some ideas of maybe how to chart some of the abnormals for the subjective assessment. Remember, that's from the questions that we ask them before we actually do the objective assessment with hands-on. And we have the same thing going on here with the objective assessment. This is a completely normal, healthy assessment within normal limits. But remember, we're not charting within normal limits right now. If you want to see the objective assessments that are a little bit off, you can once again turn to page 564 through 566 for those. So at the end of the chapter, we have our abnormal findings. Abnormal findings for abdominal distension would be obesity, any type of air or gas, and then also ascites. So that's going to be kind of a fullness from extra fluids in the abdomen. We could have a very large ovarian cyst that we can see that abdominal distension from. Of course, pregnancy is going to cause abdominal distension, and also if we have constipation with an abnormal amount of feces in the abdomen, this could cause distension, and then any type of tumor kind of protruding there out of the abdomen is going to cause distension. When we do an inspection, we could also see different types of hernias, and those are an umbilical, epigastric, incisional, and diastasis recti, and these images are listed for you on page 571. Abnormal bowel sounds. We've already talked about hypoactive and hyperactive. We did not talk about the succussion splash, and that's because this is with infants, so we're not going to be experiencing that during this class. The abnormal findings for friction rubs and vascular sounds. We may hear a peritoneal friction rub, and that's going to be more if we have a nodular type liver, or if we have an enlarged spleen, or maybe with an abscess or a tumor, then they're going to rub against that peritoneal cavity, causing that friction rub that we may be able to hear. The vascular sounds, a bruit, if we hear it over the aorta, it's going to be an aortic aneurysm more than likely. If we hear it over where we have our renal arteries, that's probably more of a stenosis finding, a hardening of those arteries, or maybe some plaque buildup. And if we hear it over the femoral arteries, we may have an occlusion of some type there. And a venous hum is something we very rarely ever hear. If we do, it's usually around the belly button area, and it's from the inferior vena cava, but we very rarely ever hear that. Now for palpation, what we're probably feeling are enlarged organs or an aortic aneurysm, which we really don't want to palpate. And you can see images for those starting on page 573. That enlarged liver is going to come down well below the rib cage, and also the enlarged nodular liver, and it's not going to feel nice and smooth. It's going to feel kind of rough. An enlarged gallbladder would be pretty difficult to feel, but the enlarged spleen, if you look on page 574, you can see how enlarged it can actually get before it would burst. Almost that entire left side of the abdomen. Enlarged kidneys, you can see it would come down below that rib cage, and then the aortic aneurysm. Remember, we don't necessarily want to palpate that. Now, if we just happened across it when we're palpating, that's a different story, but we're probably going to be hearing a bruit. At the end of the chapter, we do have a summary checklist there for us with inspection, just kind of reminding you what comes under each of these categories. Contour, symmetry, umbilicus, skin, any type of pulsations or movement, also hair and demeanor because of the possibility of pain. Auscultation, we're looking at bowel sounds mostly, and then noting any vascular sounds we may hear. Percussion, remember we don't do this a lot, but it's something we're going to try in the lab. And then palpation, definitely looking for tenderness, but mostly if we're going to look for organs, it's going to be the liver and the spleen. Okay, we do have a couple of NCLEX style questions here for you. The nurse is suspecting appendicitis. How should we proceed with the assessment of the patient's abdomen? If you want to pause the video at this point and kind of look at each option, that would be good. I'm going to go ahead and give you the answer, and it is 4. We're going to palpate last, because remember, we don't necessarily want to do what's going to elicit all of that pain first. So we're going to palpate last and note any rebound tenderness at McBurney's point, and that's right there in the lower right quadrant. So we have a nurse that's assessing a patient's abdomen and notes a bruit in the right upper quadrant. What should we suspect at this time? And this is going to be a possible abdominal aortic aneurysm. This is definitely not a normal finding. And it's not appendicitis or gallstones, and this is probably a fairly large aortic aneurysm if it's in the right upper quadrant. So we're not going to palpate that aneurysm. Please let me know if you have any additional questions related to this abdomen chapter. And I will see you in the lab.